Welcome back to the Deep Dive. So today we're tackling peripheral arterial disease, or PA. You're here probably because you need a really clear, high-yield understanding for revision, right?
Exactly.
Think of it like this. Your leg arteries are like roads, and sometimes they get congested. That's kind of what PAD is about.
Yeah, that's a good way to put it.
Our mission today is basically to pull out all the essential stuff you need to know about PAD from the notes, make it easy to grasp, easy to recall.
Making it stick, yeah.
We will mention the really severe end of things, that's acute limb-threatening ischemia, the 6PS.
Ah, yes, the classic 6PS, pale.
Pulseless, painful, paralyzed paresthetic, and cold.
Yeah.
Important to know, but our main focus is the wider picture of PAD today.
Right, because PA covers a spectrum.
And we might briefly touch on how a big difference in blood pressure between your arms, say 15 points or more, could point to a narrowing higher up, like near the subclavian artery.
That's a good related point, yeah. Subclavian stenosis.
Okay, so let's dive in. We'll break it down, maybe find some memory hooks to help it all sink in.
Sounds good. So PAD, peripheral arterial disease. Fundamentally, it's narrowed or blocked arteries.
Okay.
And it mostly affects the legs. The usual suspect behind this. Atherosclerosis.
Right. Atherosclerosis. We hear that term a lot.
Yeah, it's where plaque, a mix of fats, cholesterol, calcium, other substances builds up inside the artery walls.
So it literally narrows the pipe.
Exactly. It shrinks the space for blood to flow through. And that means less blood and, crucially, less oxygen gets to the tissues, especially in your legs.
Okay, so if the arteries are highways, atherosclerosis is like, well, a slow-motion traffic jam building up.
That's a perfect analogy, actually. It's progressive. It doesn't happen overnight.
So what actually causes that? What starts the atherosclerosis, this buildup?
Well, atherosclerosis is the process, the underlying mechanism. It's that slow accumulation inside the artery walls, making them narrower and stiffer over time.
Right, stiffer too. Makes sense.
And yeah, it just makes it harder for the blood to get through properly.
So who's most likely to run into these arterial traffic jams? What puts someone at higher risk?
Okay, risk factors. There are quite a few key ones, and sometimes grouping them helps.
Yeah, please.
So lifestyle stuff is huge. Smoking is, well, it's probably the biggest modifiable risk factor.
Yeah. Okay.
Then there's diet, a poor diet, obesity, being overweight. And just not moving enough, a sedentary lifestyle.
Okay, the usual lifestyle suspects.
Pretty much. Then you've got medical conditions. Diabetes mellitus is a major one.
Diabetes, yeah.
High blood pressure, hypertension, high cholesterol levels. Those are really important. Age is another big factor. The risk definitely goes up, particularly after 50.
Okay.
And family history. If you have close relatives with cardiovascular disease, your risk is higher too.
Makes sense. Anything else?
Yeah, a few other things. Certain less common conditions like vasculitis, which is inflammation of blood vessels, arterial dissection, a tear in the artery wall, and arterial embolism, where a clot travels from somewhere else and blocks an artery.
Got it. So smoking, diabetes, age, hypertension, cholesterol, those seem like the really big ones to remember.
Absolutely. They are key.
So we know atherosclerosis is the problem. It narrows the arteries. Can you walk us through the pathophysiology a bit more? What happens inside the body as this progresses?
Sure. So as those arteries get narrower and narrower because of the plaque, less oxygen-rich blood can reach the muscles and tissues downstream, mainly in the legs.
Okay.
This lack of oxygen supply is called ischemia.
Ischemia, right.
Initially, you might only notice it when you're demanding more oxygen, like during exercise. That's the classic intermittent claudication, that crampy pain in your calf, thigh, or buttock that comes on with walking and goes away when you stop.
The shop window pain, some people call it.
Exactly, because people stop and pretend to look in shop windows while they wait for the pain to ease. As the blockage gets worse, though, the ischemia becomes more severe.
So it happens even without exercise?
Yes. You can start getting pain even at rest. We call that ischemic rest pain. It's often worse at night, typically in the feet or toes.
Oh, that sounds nasty.
It is. And in really severe cases, the lack of blood flow can actually cause tissue damage. So you might see sores or ulcers, especially on the lower legs or feet, that just won't heal.
Non-healing ulcers, okay.
And in the most critical situations, it can lead to gangrene, which is tissue death.
Wow.
And there's another thing, those atherosclerotic plaques themselves can be unstable.
What does that mean?
Well, they can rupture or crack, and this can trigger a blood clot to form right there on the plaque. That's thrombosis. Or a piece of the plaque or clot can break off and travel downstream, blocking smaller vessels. That's embolism.
So the plaque itself can cause sudden blockages too.
Precisely, increasing the risk significantly.
Okay, so that classic leg pain on walking intermittent claudication sounds like a key symptom. But you mentioned other things can cause leg pain. What else should be on our radar? What are the differentials?
Absolutely critical point. You can't just assume leg pain is PAD. There's a whole list of possibilities.
Like what?
Well, simple musculoskeletal stuff like muscle strains or arthritis in the hip or knee.
Okay.
Venous problems like venous insufficiency, where the veins aren't returning blood properly. That can cause aching and swelling.
Right. Veins versus arteries, different system.
Totally different. Then there are neurological issues. Peripheral neuropathy, especially common in diabetes, can cause pain, numbness, tingling.
Nerve pain. Yeah.
Sciatica pain radiating down the leg from nerve compression in the back. Spinal stenosis, narrowing of the spinal canal, which can also compress nerves and cause leg pain, often worse with standing or walking, but may be eased by leaning forward.
Okay, so back problems mimicking PA.
Exactly. Also, think about deep vein thrombosis, DVT. A clot in a deep vein usually causes swelling, warmth, and pain, but it's acute. Compartment syndrome, usually after trauma, is another acute cause of severe leg pain.
Yeah.
Skin infections like cellulitis can cause pain and redness. Nerve compression syndromes, maybe in the ankle or foot. Even just a muscle or tendon injury.
So a lot to consider.
Definitely. And remember, PAD often hangs out with other cardiovascular diseases. Coronary heart disease, cerebrovascular disease, they share the same risk factors.
Makes sense.
And a really key point, if a patient with diabetes develops a foot ulcer, you must think about PAD and assess for it urgently. Poor blood flow severely hinders healing and massively increases amputation risk.
Got it. Diabetic foot ulcers equal urgent PAD assessment.
Okay.
So how common is this? You mentioned it increases with age. What are the numbers like, say, in the UK?
Yeah, it's pretty common, especially as people get older. In the UK, the estimates suggest around 20%. That's 1 in 5 people over the age of 60 have some degree of PAD.
1 in 5 over 60.
Wow. And it tends to be diagnosed a bit more often in men than in women.
Okay.
If you look at specific age groups, maybe 4 to 12% for those aged 55 to 70, but that jumps quite a bit, up to 15 or even 20% for people over 70.
So it really ramps up with age.
It does. And thinking about that subclavian stenosis we mentioned earlier, narrowing in the arm artery, that's seen in about 2% of the general population, but it's much higher, maybe around 9%, in people who already have PA in their legs, sometimes called LED, lower extremity arterial disease.
Right. LED-D. Okay, so it's definitely a significant issue prevalence-wise.
No doubt about it.
Okay, we're getting a good picture. We know what it is, the risks, what's happening inside. How does PAD actually present? What signs and symptoms would a patient come in with, or what might we find?
It really varies depending on the severity. We've talked about intermittent claudication, that predictable exercise-induced leg pain relieved by rest. That's often the earliest symptom people notice.
A classic sign.
Yeah. As it gets worse, you get ischemic rest pain, that constant ache, often in the foot, worse at night when the leg's elevated.
Okay.
You might see physical signs too. Those non-healing ulcers or wounds, typically on the lower leg, ankle, or foot. The affected limb might feel noticeably colder than the other one.
Cold feet, literally.
Literally. And when we examine the pulses in the foot, the dorsalis pedis or posterior tibial artery pulses might be weak or even completely absent.
Ah, checking pulses is key then.
Absolutely crucial part of the exam. Over time, you can also see skin changes on the legs and feet, maybe hair loss. The skin might look thin, shiny, and fragile.
Right, trophic changes.
Exactly. And in men, sometimes impotence or erectile dysfunction can be an early sign due to blocked arteries supplying the pelvis.
Isn't that one?
Yeah, iliac artery disease often causes it. And then, in the most severe, untreated cases, you can see gangrene tissue death, often starting in the toes.
Grim.
It is. So taking a good history is vital, asking about the claudication, rest pain, any wounds, and really drilling down on those cardiovascular risk factors we talked about: smoking, diabetes, hypertension, family history.
History is key.
And tools like the Edinburgh Claudication Questionnaire can be useful too, to sort of standardize the symptom assessment. And always, always keep those 6 Ps in mind for acute limb ischemia: pale, pulseless, painful, paralyzed, paresthetic, cold. That's a vascular emergency. Needs immediate action.
Right. The 6 Ps for emergency. Got it. So if someone presents with symptoms suggesting PAD or we find those weak pulses, what are the next steps? How do we investigate and confirm it?
Okay, investigations. We usually start with non-invasive tests. The cornerstone is the ankle brachial pressure index, the ABPI.
ABPI.
It's simple, cheap, and gives us really valuable information. We measure the systolic blood pressure at the ankle and compare it to the systolic pressure in the arm.
How does that help?
Well, normally the pressure in the ankle should be the same or slightly higher than in the arm. So the ratio ankle pressure divided by brachial arm pressure should be about 1.0 or a bit more.
Okay.
If there's significant narrowing in the leg arteries, the ankle pressure will be lower, so the ABPI ratio will be less than 1. Usually, an ABPI less than 0.9 is considered diagnostic of PA.
Less than 0.9. Okay.
And the lower the value, generally the more severe the disease. Below 0.5 often indicates critical limb ischemia.
Gotcha. What else?
Often, the next step, or sometimes the first step in clinic, is using a handheld Doppler probe to just listen for the pulse signals in the feet. If signals are present, we proceed to the ABPI measurement.
Right.
Then, to get more detail about where the blockage is and how bad it is, we use Doppler ultrasound, specifically duplex scanning.
Duplex scan.
Yeah, it combines regular ultrasound imaging with Doppler to visualize the artery structure and measure blood flow velocity. It can pinpoint stenosis or occlusions. It's really the main imaging test now.
Okay, so duplex is key for mapping it out.
Definitely. For more complex cases, or if we're planning intervention like surgery or angioplasty, we might need more detailed imaging like angiography.
Angiography. That involves dye.
Yes. Traditionally, it was catheter-based digital subtraction and angiography, DSA, injecting contrast dye directly into the arteries and taking x-rays. Now, we often use CT angiography, CTA, or MR angiography, MRA, which are less invasive. DSA is still sometimes needed, especially during interventions.
Okay. And blood tests.
Yeah, important to check for those risk factors we discussed. So a full blood count, FBC, maybe ESR if we suspect inflammation like vasculitis, definitely fasting blood glucose or HbA1c for diabetes, and a full lipid profile for cholesterol.
Check the risk factors.
Exactly. An ECG is usually done too to check for any underlying coronary heart disease, as it's often linked.
Makes sense.
And in younger patients, say under 50, presenting with PED, we might do extra tests like a thrombophilia screen to look for clotting disorders and check serum homocysteine levels, as these can be rarer causes.
Okay, specific tests for younger patients. Good to know. When would you refer someone to secondary care, to the specialists?
Good question. Referral is needed if there's uncertainty about the diagnosis. If symptoms are severe or not responding to initial management, if you're considering revascularization, angioplasty, or surgery.
Okay.
Also, if the patient's risk factors are proving really difficult to manage in primary care, if their symptoms are significantly limiting their lifestyle, and we've objectively confirmed arterial disease with ABPI or duplex, and definitely refer younger adults with premature claudication to exclude those rarer causes.
Right. Clear criteria there. So let's say we've diagnosed PAD. What's the management plan? What do we do?
Management is multifaceted. If it's an acute limb ischemia situation, those 6 Ps, that's an emergency. Initial steps are the ABCs, good pain relief, often opioids, starting anticoagulation, usually with heparin, and an immediate referral to the vascular surgery team.
Okay, ABC, analgesia, heparin, urgent referral for acute.
Exactly. Definitive treatment for acute might involve thrombolysis, clot-busting drugs, embolectomy, surgically removing the clot, maybe angioplasty or bypass, or in the worst case, amputation.
Right. But for the more chronic, stable PAD.
For chronic PAD, the focus is on reducing cardiovascular risk and improving symptoms. Managing comorbidities is absolutely crucial.
Like the hypertension, diabetes.
Yes. Strict control of blood pressure, blood sugar, and lipids. So medications like ACE inhibitors or ARBs for blood pressure, metformin or other agents for diabetes, and definitely statins for cholesterol, usually high-intensity statins for nearly everyone with PAD.
Stands for everyone.
Okay. And antiplatelet therapy is key to reduce clot risk. Usually low-dose aspirin or sometimes clopidogrel if aspirin isn't tolerated or in certain situations.
Antiplatelets. Right.
Then there's lifestyle modification. Smoking cessation is paramount, probably the single most effective thing a patient can do.
Stop smoking. Non-negotiable.
Absolutely. Healthy diet, weight management if needed, and supervised exercise programs are really important for claudication.
Exercise helps, even though it causes pain initially.
Yes. Supervised exercise therapy, typically walking on a treadmill to the point of near maximal pain, resting, then repeating several times a week, has been shown to significantly improve walking distance and quality of life. It helps develop collateral circulation and improves muscle efficiency.
Ah. Okay, exercise is medicine here.
It really is. For claudication symptoms specifically, sometimes medications like naftalfuril or celestazol might be considered if lifestyle changes and exercise aren't enough, although their effectiveness varies.
Okay, drugs for walking distance.
Then, if symptoms are severe or disabling, or if there's critical limb ischemia, rest pain, ulcers, gangrene, we consider revascularization.
Procedures to improve blood flow.
Right. This could be endovascular, like balloon angioplasty, maybe with stenting to prop the artery open, or open surgery, like bypass grafting, where a vein or synthetic tube is used to reroute blood flow around the blockage. The choice depends on the location and extent of the disease and the patient's overall fitness.
Endovascular first, if possible.
Often, yes, it's less invasive, but surgery is sometimes necessary for more complex blockages.
In amputation.
That's really the last resort, reserved for cases of critical limb ischemia where revascularization isn't possible or has failed, and there's non-salvageable tissue or intractable pain or infection. It's a major decision made by a multidisciplinary team.
Okay, wound care too, for ulcers.
Absolutely. Specialist wound care is vital for any ulcers or tissue damage to promote healing and prevent infection.
So a really comprehensive approach. Risk factors, lifestyle, meds, exercise, procedures if needed.
That's the goal, a holistic approach.
What's the long-term outlook then? What's the prognosis for someone diagnosed with PAD?
It's quite variable, but the key message is that PAD is a marker of systemic atherosclerosis. So the biggest risk isn't actually losing the limb, it's cardiovascular events like heart attack and stroke.
Right, the systemic nature of it.
Yeah. For someone with just intermittent claudication, the 5-year mortality risk from cardiovascular causes is somewhere around 10 to 15%. Overall, having PAD roughly triples your risk of dying from a cardiovascular cause compared to someone without it.
Triples the risk, okay.
The leg symptoms themselves can progress differently. Over 5 years, most people with claudication stay relatively stable symptom-wise, especially if they manage risk factors.
This guy.
But maybe 10–20% will find their walking gets worse, and about 5–10% will progress to critical limb ischemia.
Okay, and amputation risk.
For those with just claudication, the 5-year risk of needing an amputation is relatively low, maybe 1–2%, but it's significantly higher, around 5% or maybe more, in people who also have diabetes.
Diabetes makes it worse.
Definitely. Now, if someone already has critical limb ischemia, the prognosis is much more serious. That reflects severe, widespread atherosclerosis. Their risk of heart attack, stroke, and vascular death is significantly elevated, maybe tripled compared to those with just claudication. And sadly, even with treatment, the amputation rate within 1 year for critical limb ischemia is quite high, perhaps around 30%.
30% within a year. Wow.
And acute limb ischemia also carries a high mortality rate, maybe 15–20%, and outcomes are worse if treatment is delayed.
Time is critical there.
Absolutely. And having an amputation itself carries a poor prognosis, higher risk of problems with the other leg, complications, and increased overall mortality.
So the key message is early diagnosis, aggressive risk factor management, and lifestyle changes are crucial for improving these outcomes.
Exactly that. It can make a huge difference.
What about complications specifically? What can go wrong beyond the progression of the disease itself?
Well, there are several potential complications. We've touched on some. Obviously, the reduced mobility and pain severely impact quality of life.
Yeah.
There can be psychosocial issues, too, like depression, especially in advanced PP.
Understand.
Acute limb ischemia from a sudden thrombosis or embolism is a major complication we've discussed. Infection is a big risk, especially if there are ulcers or wounds, because the poor blood supply hinders the body's ability to fight it off and heal.
Right, poor healing.
Ulceration and gangrene are complications of severe ischemia, potentially leading to amputation.
Okay.
The treatments themselves can have complications, bleeding, infection, damage to blood vessels during procedures.
Risks with interventions.
Yes. And again, because PAD signals widespread vascular disease, there's that increased risk of systemic vascular complications. Heart attack, stroke, even vascular dementia.
Right, the whole cardiovascular system is affected.
Exactly. In acute limb ischemia specifically, if it's severe and prolonged, you can get multi-organ dysfunction. 2 specific complications of acute limb ischemia are worth knowing. Compartment syndrome.
Compartment syndrome.
Yeah, after blood flow is restored, or sometimes just from the initial injury, swelling can occur within the confined muscle compartments of the leg. This increases pressure, which can compress nerves and remaining blood vessels, causing further damage. It might require surgical decompression, a fasciotomy.
Okay, swelling causing more problems.
And the other is reperfusion injury. When blood flow returns to tissues that have been starved of oxygen for a while, the returning oxygen can paradoxically trigger inflammation and release of harmful substances from damaged cells, causing further tissue injury.
Wow, even restoring blood flow has risks.
It can, yes. It needs careful management.
This has been incredibly thorough. Thanks. To really help cement this for revision, do you have any handy mnemonics or maybe some example questions we could think about?
Definitely. We already mentioned the 6PS for acute limb ischemia, pale, pulseless, painful, paralyzed, paresthetic, cold. That's essential.
6PS. Got it.
For risk factors, maybe something like SMART-H, smoking, male, more common but affects all, age, relations, family history, type 2 diabetes, and type 1 hypertension. It doesn't cover everything like cholesterol or inactivity, but hits some major ones.
SMART-H. Okay, useful. How about a question?
All right, try this. A 68-year-old man with type 2 diabetes and a 40-pack year smoking history complains of pain in his left calf after walking about 50 yards. It forces him to stop, and the pain resolves after a minute or two of rest. He's noticed this for the past few months. On examination, his left foot feels slightly cool, and the posterior tibial pulse is absent. What is the most likely underlying pathophysiology? A. Venous incompetence. B. Nerve root compression. C. Atherosclerotic arterial narrowing. D. Deep vein thrombosis. E. Musculotendinous inflammation.
Okay, so smoker, diabetic, classic claudication description, absent pulse, that points strongly toward PE. C. Atherosclerotic arterial narrowing.
Exactly right. The history and findings are classic for PA caused by atherosclerosis. Okay, one more. Which single investigation provides the most useful initial objective assessment for suspected PAD in primary care? A. Duplex ultrasound. B. CT angiography. C. Ankle brachial pressure index, ABPI. D. Blood cholesterol level. E. Edinburgh claudication questionnaire.
Useful initial objective assessment. Duplex and CT are more detailed imaging. Cholesterol is a risk factor test. The questionnaire is subjective symptoms, so it has to be C. ABPI.
Perfect. ABPI is the key initial objective measure of lower limb perfusion.
Great examples, thanks. So quick summary. PAD, narrowed leg arteries, mainly from atherosclerosis. Risks: smoking, diabetes, age, hypertension, high cholesterol. Symptoms range from claudication, pain on walking, to rest, pain, and ulcers. Differentiate from other leg pain causes. It's common, especially in older adults. Check pulses, measure ABPI, maybe use duplex. Management involves risk factor control, statins, antiplatelets, BP glucose control, smoking cessation, exercise, sometimes meds like naftotrafuril, and revascularization, angioplasty surgery for severe cases. Prognosis is tied to overall cardiovascular risk. Complications include acute limb ischemia, ulcers, amputation, and increased heart attack stroke risk.
You've got it. That's a really solid summary of the core information. Hopefully that breakdown helps make it more manageable for revision.
Definitely. And thinking about that link between PAE and systemic cardiovascular risk, it really drives home the importance of prevention and early aggressive management, doesn't it?
It absolutely does. Improving early detection and ensuring optimal risk factor management across the board are probably the biggest areas where we can make a difference to long-term outcomes. Reducing smoking rates, better diabetes, and blood pressure control, it all feeds into reducing the burden of PAD and its consequences.
A crucial public health challenge, really.
Don't worry.
Well, we really hope this deep dive into peripheral arterial disease has been genuinely helpful for your MSRA prep. Remember, you can find more revision resources over at PassTheMSRA.com.
And also check out freemsra.com for, free questions and materials.
Excellent point. Thanks again for joining us on the deep dive, and good luck with your revision.